Okay. Good afternoon, everybody. Make sure you stay on camera. Every once in a while, there's a phantom that comes through and watches for everyone staying on their camera. Okay, so I was telling everybody else that after we're finished class today, I'll be glad to go over the exam as far as major concepts that might have been misunderstood or not known. And also quiz 4. I want you to know what's right, what some things students missed. Okay, so I am updating week 8 announcement with recordings. So there's quite a few there now. There's quite a bit for you to look at, and there's a PowerPoint that has everything on it. There's a lot there, so take advantage of those. And then there's also the schedule for, once again, study sessions for your exam next week. Okay. So if you didn't get all your assignments done, like your discussion post from last week, please finish it. You need every little point possible, right? Every partial point, whatever you can get. Okay, so get that done this week. And then plan when you're going to go to a live session. Now, consider what you got on the first exam and think about how you prepared for the second exam. What could be some strategies for your third exam? Okay, because remember, you really need a healthy 86% or so going into the HESI. Gives you a little buffer room there. So I'm not saying you can't do well if you're at 78% KGA when you go into the HESI. You still can pull it off, okay? But you'd have to get 78%, okay? So we have quiz 5 today, and you have your preterm newborn case study this week. Remember, take your time, open the book, look at your notes, and get the right answers. And then you have a 4th discussion and also an NCLEX question. So there's a lot to do this week. Your NCLEX questions need to be health problem, and I put this in the announcements. The category health problem, subcategory newborn, and then postpartum. Okay, health problem. All right. So everybody get signed on to their Canvas. Get your Canvas opened up and go ahead and begin your quiz. It should be available by now. Let me double check. So go ahead and start if you haven't.
Hello.
Righty. I think Ezzy is still working, but she's off Zoom now anyway. She had internet trouble. All right. So let's do a case study together, okay? So Rocky, go ahead and turn your camera back on, please. All right, so let's read about you're receiving a newborn. You're working in postpartum. And this is your new client, your newborn that you're going to have assigned to you. Go ahead and read that, and we'll begin to answer some questions together. So 4.4 kilos, is that a big baby? How many kilos is that? Or grams, I should say. How many grams is that? Okay, we just have to move the decimal point over 3 places. So it's 4,400 grams. Is that a big baby? Yes. You can unmute yourself to speak. Okay, so big baby, labor dystocia, not uncommon. Okay, what client? Well, it tells you here, difficult labor and failure to progress. Okay, so the mother has a history of gestational diabetes and high blood pressure. Okay, what is your number one concern about this newborn who weighs 4,400 grams?
Blood sugars.
Okay, so blood sugar, so we're concerned about early onset hypoglycemia. What else might you be concerned about?
Jaundice.
Jaundice from what?
From bilirubin? I think that's how you say it.
That is how you say bilirubin. Where is this baby's bilirubin levels? Why would they be elevated?
I remember what I remember that they could have it. I just don't remember why they have it.
Okay. So there's and we'll go over bilirubin today, but there's really no indication of concerns with bilirubin on this baby. Okay. But what else? What else do you think? Keandra, what else would you be concerned about? You have this large baby. Baby was delivered C-section. A mother has a history of diabetes and hypertension. So we've already mentioned hypoglycemia. What else could be going on with this newborn? You haven't seen the baby yet, but you know, as a nurse, what you could expect with a big baby like this.
Maybe respiratory issues.
Okay, respiratory issues for 2 separate reasons. Okay, a cesarean section and hyperglycemia. Okay, what else? Difficult labor and failure to progress. What if it wasn't a C-section? What if it was a vaginal delivery? What would you be concerned about?
Shoulder dystocia.
Okay, shoulder dystocia. Anything else? So 4,400 gram macroscopic baby. gestational diabetes, hypertension. What else might have occurred during labor and delivery? The big baby.
If the baby possibly gets stuck.
Okay, so we talked about the shoulder dystocia, and we talked about the failure to progress, which is probably like a cephalopelvic disproportion. The head wouldn't pass through the pelvis. So what about birth injuries? Okay, so we talked about shoulder dystocia. So birth injuries such as brachial plexus injury, broken clavicle, broken humerus, cephalohematoma, a kaput. There's a lot of things that could have occurred when you have a big baby, a difficult labor. And if we had to use vacuum assisted delivery or forceps, then we have to add more potential problems. Okay. So we, other than the difficult labor, what else about the mother's history that led to the need for a C-section? Not baby's history, mother's history. Any idea? How about just gestational diabetes? So if you have a diabetic client antepartum and they're gaining more than adequate weight and the ultrasounds are telling you your baby is above the 90th percentile, then you're going to think dystocia, shoulder dystocia, birth injuries, okay, because of her diabetes. Okay, this is to help you put it all together, okay? Okay, so yeah, a little respiratory distress. So remember, respiratory distress in babies of diabetic mothers is because the insulin levels were so high during the pregnancy to try to open up those cells for glucose that it diminished the ability of the surfactant to be reproduced or to be produced. So they tend to have a little bit of distress. So we've had to actually put CPAP on this baby, which is continuous positive airway pressure to keep the airway open during the respirations. And we only put a baby on room air. Okay, it's not that this baby needs oxygen, they just need ventilation. Okay, so the baby has an IV infusing because of mother's situation. So we've got some glucose, some dextrose infusing at a very low rate. And he's got an oral gastric tube in place, feeding tube. The nurse notices that the newborn has momentary decreases in oxygen saturation. So it kind of dips down every once in a while to 82%. Okay. Respiratory rate is 75 to 90. Is that high or low? Or is it okay? Do you remember what the normal respiratory rate is of a newborn?
Would it be low?
If you don't know, then look it up. Okay, somebody tell me what the normal respiratory rate is of a newborn.
Is it 110?
Respiratory rate. Respiratory rate.
$30 to $60.
Yeah.
30
to 60. Okay, so respiratory rate of 75 to 90 is indicative of either the respiratory distress syndrome, inadequate surfactant, or because of the C-section, there's still some retained fluid in the lungs, okay? Like a transient tachypnea, okay? What other things would you see if your newborn was experiencing respiratory distress besides tachypnea?
Use of accessory muscles.
Okay, use of accessory muscles. Good. So some retractions. What else?
Flaring, nasal flaring.
Nasal flaring. What else?
Grunting.
Grunting. Okay. Okay.
They'll have this cyanosis, central cyanosis, if it's
Okay,
super
yeah, they're
bad.
going to develop, yeah, the bluish tinge, yeah. Okay, so what treatments do we provide? So we have CPAP going. O2 saturation is dropping a little bit. We might bump up the oxygen a little bit, right? We don't want to give this newborn too much oxygen, so we might put it at 2 liters, 24%. Okay, what else do we need to do for this newborn? If it's tachypnea, transient tachypnea with excess fluid in the lungs, and you auscultate the lungs, what would you hear?
Wheezing.
Okay.
Crackles.
You might hear some wheezing. What else?
Bronchi.
Or some rails, some popping. Okay. All right. All right. So then we would probably want to get an x-ray to look at the chest to see if it's just fluid or if it's indeed surfactant levels are too low. So we might see a lot of atelectasis, okay, in the x-ray. Okay, so let's say our x-ray shows atelectasis. What's our treatment for atelectasis? Okay. So our treatment for atelectasis is surfactant, right? So we put that through the tube, put that in a bag. We're going to bag the baby and we're going to instill it like an aerosol into the lungs. Okay. I think that was on your quiz. 3 ml of surfactant, and we're going to use it as an aerosol to instill into the lungs to help those alveoli open up and improve the oxygenation of the newborn. And hopefully that respiratory rate will drop down. Okay, so we've got that under control. Our O2, our arterial blood gases were pH of 7.23, CO2 of 52, and oxygen of 72. And bicarb was 25. Glucometer reading was 26. And the crit was 48. All right, we treated our respiratory issues, so our gases are much improved. So the oxygen now is 90, okay? O2 is 40, and the pH is 7.38, okay? I know you probably might not know your gases yet. So, but we've got this glucometer reading of the blood glucose at 26, and that's low, okay? We like it to be above 40. So now we have to give that baby some D10, okay? All right, we kind of talked about everything else. All right. So what's our next thing that should be part of your nursing care plan? Once we've remedied the problems of respiratory distress and hypoglycemia, what are some things that you need to have as part of your care plan? Take care of this baby. You fixed it. Now you just gonna walk away and leave that baby alone? So should we follow up with our intervention? So we're going to routinely listen to baby's breath sounds, look at the oxygen saturation, look for any behaviors that might indicate distress. We're going to watch for signs of hypoglycemia, check the blood glucose as often as you're ordered to do. Okay. What are some things you see in a newborn with hypoglycemia?
Tremors or shakiness, cyanosis, not wanting to eat, seizures.
Irritability. Yeah, irritability. So newborns of diabetic mothers are at risk for hypoglycemia and respiratory distress. Okay, so we have to know what to look for to make sure we're keeping a keen eye out for signs of hypoglycemia, birth injuries, respiratory distress, and hypocalcemia. So hypocalcemia, they're going to be very lethargic, and their muscle tone is going to be poor. When a baby's experiencing respiratory distress, they also have hypotonia. Okay. Okay. Differential diagnosis is if we take a group of data, we're looking at our baby, observing and assessing our baby, and we have all these things going on. Does it mean that they're in respiratory distress, or does it mean it's just a transient tachypnea, or does it mean they're developing pneumonia? So that's what we call a differential diagnosis. So we have to assess our client, all aspects of respiration, okay? Frequent vital signs, respiratory support, okay? CPAP is very common in respiratory distress newborns. It's a positive pressure that helps keep the lungs expanded at the end of expiration, okay? We're going to make sure we have glucose available, IV site available in our newborn, and monitor that. Don't forget about temperature issues. There's a lot of temperature instability, and these babies can go into cold stress very easily, which would use up more, cause them to be even more acidotic. Okay. Providing emotional support to your mother, teaching her as you intervene, telling her what the plans are, what we need to be doing so that she can be involved. And we want these babies to breastfeed. Diabetic babies need to be breastfed every hour or two. And we're going to go over the benefits of breastfeeding again today. So let's talk about this again. This is the normal ranges of healthy newborns. It's probably in your text too. I just took this off the internet. Okay. So we really want arterial blood gas, oxygen level, pressure of arterial oxygen to be 60 minimum. Remember, they have extra red blood cells on board, so they can carry a lower oxygenation because of that. Okay. pH not any lower than 7.37, not any higher than 7.43. All right, well, that was a challenge for you. That was a combination of, like I said last week, of just normal. You need to know the normal so you recognize the abnormal. I want to show you a video. Let's see here. Smoke alarm going off. Oh dear, better check for the fire. Samantha, is everything okay? Where is she? Are you here?
Yeah.
Oh, there
I'm
you are. Somebody cooking in the kitchen?
No, it just keeps going off. It's going off again, but
That's because you might need to replace the battery. Yeah. Okay, let's watch a video. And this video is from that global network that I really like. They have really good videos to watch. So we'll watch this together. I hope you can hear it. Let me know if you can't. So tell me what you're seeing here. You might have to turn up your sound. Okay, that was fast. So what was that?
That was the intercostal retractions.
Yeah, actually they were inter and subcostal retractions. That baby was having some respiratory distress. It didn't look like he was having any of that paradoxical breathing going on. The seesaw respirations. That's another sign of severe distress. Okay, good. So let's talk about breastfeeding for a minute. I'm going to pull up this breastfeeding slide set from last week because we can talk about, let's see, breastfeeding PowerPoint. The importance of promoting breastfeeding for especially the diabetics, but well, especially for everybody, but diabetics. So newborn nutrition, the best nutrition for a newborn is breast milk. And yes, a lot of the commercial formulas out there like Similac and Enfamil and all the other ones are good. They're as close to breast milk as they possibly could be. And they do have everything that a newborn needs for at least 6 months. Okay, so I don't ever want a mother to feel like she's short-sighted or didn't provide her newborn with everything that she could, even if she had to choose to do formula. That's okay. And then we do provide fluoride supplementation after that, little drops. But that is a countywide mandate. Okay, so breast milk helps establish the normal bacteria in the intestinal tract earlier than formula does. Breast milk has more fatty acids in it for good neurological development and all the vitamins. Plus, breast milk has the IgA immunoglobulin, which helps the newborn to fight bacteria, viruses. It also helps a newborn not to develop as many allergies later in life. It reduces the development of type 1 diabetes later in life. So these are huge. And in your book on page 583, it has a lot more listed. Okay, so not everybody can breastfeed. Okay, so contraindications, if our client has HIV, if they have a viral load that's undetectable, even then it's not recommended they breastfeed. Ebola virus, a newborn with inborn errors of metabolism, like PKU and galactosemia. Galactosemia is a lot of galactose, which is a sugar that's in the blood. Okay, so if a newborn can't metabolize a certain kind of sugar, then we don't want them to breastfeed. Any illicit substance use or any substance that would be harmful to the newborn. So that includes prescribed medications that are not good for the baby breast milk because it could pass through the breast milk. Methadone and buprenorphine, the Subutex, there's very little that goes through the breast milk, so that is safe. And then herpes simplex virus. If there's a current outbreak on one breast, we don't want baby to drink from that breast. Okay. We can express it. Okay. But we don't want contact isolation with baby. But mother can breastfeed on the other breast. So those are some of the reasons that we don't want breastfeeding. I'm sure there's others. So colostrum is that very first substance that is produced by the breast. It's got high protein. It's got a lot of antibodies, like I said, and lower in fat than the more mature milk that the mother begins to express, usually about 4 days later. Okay. So in this picture on the left is colostrum. And then as you go to the right, it's mature milk. Okay. So the benefit of colostrum, other than the immunoglobulins, it actually helps the bilirubin levels be controlled. It helps it conjugate. And colostrum is a laxative. So the baby passes stool so easily. And that helps get rid of any excess bilirubin. Sometimes what we see with breastfeeding is that, especially if it's a new mother, the first pregnancy, the baby might not be getting as much as they need. And they might become just a little dehydrated. And then we might see bilirubin levels go up. And that's called breast milk jaundice. Okay. It usually resolves itself in time once a mother gets more accustomed to breastfeeding, and we might be able to visualize jaundice. So we encourage mom to do breastfeeding more often, maybe out in the sun a little bit. Certainly got to be careful with that. So remember what the cycle of milk production is. So we've got prolactin and oxytocin being released from the pituitary gland. Okay, so prolactin instructs the breast to make milk. Okay, oxytocin tells the breast to release the milk. Okay, so both of them are needed. Okay, so milk is ready to go, and baby suckles, which stimulates the brain again to release more pituitary hormones. So the more the baby breastfeeds, the more milk that's produced. So as that baby grows, the milk will grow with it. The amount of milk will grow with it. Vice versa, if mother skips a feeding and doesn't allow suckling or doesn't release the milk from that breast, then the production of milk drops down. So we need to continuously explain to mother, if you're sick and you don't feel like breastfeeding, hopefully she saves some milk, then make sure you express milk from that breast sometimes so that you don't get behind on your milk. So what are some things we would see in a newborn that's hungry? We call them feeding cues. Well, they're kind of cute at first. They do sucking motions. They start moving their lips around because they've got those rooting and sucking reflexes. They might put their hands in their mouth and chew on their fingers. Then they might toss their head around looking for something to eat. So they're becoming a little restless as they realize they're getting hungry. And then if they start crying, that's late signs, like do something. Okay. And as nurses, especially for those new mothers, make sure you're assessing the newborn's latching. In other words, we want a big mouthful. We want those lips to grab all the way around that dark areola, not just the nipple, but a big mouthful. And if the baby gets frustrated, mother gets frustrated, that makes it worse. If she's engorged, it's hard for a baby to breastfeed. So we could have her express some milk or colostrum and then let baby latch. If she's still having trouble, then we need to get a lactation specialist involved. So you can hear whether the baby is getting milk. You can actually hear them sucking and swallowing to know they're getting adequate milk. Okay, so this is just the same thing I was telling you earlier. Okay, so the nurse tells Nikki, which is our client, that she will help her with breastfeeding. She provides Nikki with printed information about breastfeeding and refers her to her websites. The nurse adjusts the baby's position, shows Nikki how to safely remove her from the breast, and assists Nikki with latching the baby to the breast. Okay, so as we're teaching, what are some other things that would be effective in client education? So this is a sample of a next gen question. They'll give you a scenario, and then they'll give you a list of interventions. Is that an effective intervention? Would that help? Or is it not necessary? Or is it ineffective? Okay, so you have your client breastfeeding. Okay, number one, keep the baby wrapped in a blanket during feedings so she does not get cold. Is that effective? Would that be effective at helping her to learn how to breastfeed? What do you think? Does that really help her breastfeed? No, that would be ineffective. You're wasting your time. We don't want babies to get too comfortable during breastfeeding because they'll fall asleep. Okay. What about the next one? Would that be effective?
Yes.
So yeah, we do need to show her different positions that she can hold the baby in. So that is effective. So choosing one breastfeeding position and always use that one?
No.
Is anybody else out there? So maintaining the baby's body in alignment during latch and feeding. Is this hard? Is it important that we have our baby in alignment? One of the best positions is tummy to tummy, and the head of the baby in a 15-degree elevation. So head up a little bit. So we do need to keep baby in alignment. So yes, that's effective. Using the nipple to tickle the baby's lips when her mouth is open. Yes. Breaking suction by inserting a finger. Yes. Okay. Y'all are so quiet. So it's 24 hours after delivery. Nikki has breastfed the baby every 3 hours as instructed, and she tells the nurse that she can get the baby to latch on, but she falls asleep after a few sucks. She says her nipples are sore and they appear reddened. The nurse checks the chart and notes that the baby has not yet voided or stooled since birth. The nurse evaluates whether breastfeeding is effective or ineffective. What are the signs of effective breastfeeding? In other words, what will you see in this list that indicate breastfeeding is successful and it's working well?
Okay.
Okay, yeah, I agree with that. So let's check.
B.
B.
Huh?
B.
B. Okay.
D.
E.
Yeah, for sure.
E.
Yeah. Why would mother experience uterine cramping while she's breastfeeding?
Production
Breastfeeding
of
releases
oxytocin.
oxytocin.
Oxytocin, yeah. But what about mother reports feeling drowsy while feeding? I don't think that's good. No, we don't want mom to feel drowsy. She needs to eat before she breastfeeds. Baby sucks with cheeks dimpled. No, we don't want cheeks dimpled. Okay, bilirubin, breast milk jaundice. So I talked about the importance of, for bilirubin, it's important for a baby to be feeding and stooling. That's what helps conjugate it and passes it out of the body, right? Our newborns' livers aren't mature and it's hard for the liver to conjugate bilirubin. So breastfeeding really helps, but if she's not breastfeeding adequately and the baby gets a little bit behind, they might develop what we call a physiological jaundice or breast milk jaundice, okay? So we do watch for weight gain. We want them, we expect a little bit of weight loss before they go home. Okay. So we can use our transcutaneous tester to test the bilirubin levels, the unconjugated bilirubin levels. Sometimes physiological jaundice develops because of a cephalohematoma. A hematoma on the newborn's head from delivery. So you've got blood cells, red blood cells that are broken down, which causes increased levels of bilirubin. So gavage feeding. If we have a preterm newborn who doesn't have the sucking ability or the coordination to suck and swallow, then we do still want to use breast milk. And we have to put a tube into their stomach. So I read an article yesterday that they still recommend bolus feedings. In other words, a larger amount every couple hours instead of continuous feeding. Okay. If they give breast milk, it really does protect that newborn. It improves the neurocognition. It decreases the risk of necrotizing enterocolitis, which we'll talk about, urinary tract infections, and upper respiratory infections in the newborns. We can use mother's milk, or we can get some from a bank. So this was something really important. This is from your book. So just remember that breast milk should never be heated up in a microwave. No milk should ever be heated up in a microwave unless you shake it and let it sit for a minute. But the problem is breast milk, if you get it too hot, it's not only harmful for the baby, but it actually breaks down some of the nutrition in that milk, like vitamin C. Okay. So your clients that are breastfeeding, is Subutex safe? Yes. Alcohol? No, we don't want any alcohol because it passes through the milk. We can't give smallpox vaccines to a breastfeeding mother. COVID is safe. So far, we've recognized COVID is not passing through the breast milk, so it is safe to give COVID with mother breastfeeding. Drug use? Absolutely not. Nicotine will actually reduce milk production, and it also exposes your baby to secondhand smoke. So it's not recommended for smoking with a newborn. So what's this a picture of? What's this picture?
Mastitis.
Mastitis. So how do we manage? What are the nursing interventions here? What do we do? What are we teaching mom? How do we treat it?
Can't you use heating pads?
Okay, we call them warm compresses, moist, warm, moist. Oops. Okay, warm, moist compresses.
We would also teach her that you can still breastfeed with it.
Continue to empty the milk, breastfeed, whatever's comfortable. Even if she's on an antibiotic, which she will be. Because if we don't empty the breast, it's going to get worse. What else can we do? Can we do some ibuprofen? Yes. Or some kind of anti-inflammatory. Is acetaminophen an anti-inflammatory? Is Tylenol an anti-inflammatory?
No.
No, it's not. Okay. Well, so far, I've been doing a lot of talking. Okay, so I need some engagement here. If you have to, get your notes out, get your book out or something. I want some engagement. Let's see, what should we do next? Do you want to take a break and then we'll do the rest of high risk? Okay. So let's break until 15 after the hour. And then we'll do high risk lecture and discussion. Okay. So ask good questions as we go through it. Okay. And let's work on this together so you understand about the newborn. Okay, so let's review some things from last week. Remember, after delivery, we want to secure warmth and stability for our newborn. Once we know baby is not in any obvious respiratory distress, then we need to put baby on mother's chest, skin to skin. We call it skin to skin. This stabilizes temperature. So baby, the heat from mother is conducted to the baby. It stabilizes the cardiac function and respiratory function. And it certainly is an opportunity to facilitate bonding and to begin breastfeeding as soon as possible. Remember, babies' reflexes are very functional at this point. So we do an APGAR 1 minute after birth, and then at the 5th minute after birth. So let's review the APGAR. APGAR, basic instrument we use at all deliveries. It's a consistent tool, so we can compare infant or newborn to newborn. So appearance is referring to the color, the heart rate, reflex activity, movement and activity, and then respirations. Okay, so 10 is a perfect score. Baby's not having any difficulties. 0 means they're not responding, they're blue, no heart rate, no crying, no nothing. Okay, so usually APGARs of 5 and under considered moderate stress. 3 and under then would be severe distress. An average APGAR would be from anywhere to 7 to 10. Okay, so at the 1st minute mark, we do it. And then at the 5th minute, we want to see some improvement. So as far as appearance, remember the acrocyanosis. You're only going to score your newborn 1 point if the hands and the feet are a little bluish. And this has nothing to do with respirations. Okay, it's about immature circulation. Okay, and then we want the heart rate to be above 100. We want the baby to respond to any kind of stimulation. We want them to withdraw. We want to see their reflex activity. If we try to pull up on the baby's arms, the baby's going to have some resistance to that. That would be scored as a 2. So that's good. We want legs and arms moving both. Very active baby is a sign of a healthy baby. And then respirations, a nice strong cry. Respirations between 40 and 60, or what did I say? Above 30 to 60. Above 30 and 60 or below. And then once we know baby is stable, put on mother's chest, and we're going to leave that baby there and bonding with mother, breastfeeding, staying warm for a couple hours before we need to do anything else. Once that couple hours is over, we need to go ahead and instill some erythromycin gel into the eyes and give that newborn vitamin K. So vitamin K is a substance that a newborn doesn't have for at least a week. Vitamin K is produced by bacteria in the gut. Okay. So babies, unless they've fed for several days, usually a week, they don't have any bacteria. So we need to give them that vitamin K. So we do the eyes and the thighs. And then when mother is tired enough, we'll do a more head to toe detailed assessment. So that's a little bit of review from that. Okay, so let's go ahead and talk about high risk now. Now, if I say something and you don't understand it, you have no clue what I'm talking about, please interrupt me. I mean, we're here to learn, and it's okay not to know something. All right. Yes, it would be nice if you would have the ability to prepare for class, because then after class, you wouldn't have as many questions and concerns. Okay, so high risk neonate. So a neonate is just a newborn within that first 24 hours. Okay, newborn goes to 30 days. Okay. All right, so gestational age, a preterm baby, post-term baby, a low birth weight baby, a large baby are all at risk for difficulties in the postpartum period. And there's others, okay? But generally, they can be categorized in that manner, okay? So when we think about all the ways that we diagnose high-risk babies, it's the different categories: birth injuries, infections, NAS, fetal alcohol syndrome, some kind of a hemolytic condition, and then hyperbilirubinemia, preterm and postterm. Okay, so symptoms of NAS, fetal alcohol syndrome. So this baby here is fetal alcohol. This one is jaundiced. Who knows the difference between jaundice that develops after delivery versus jaundice that develops in utero, and maybe baby is born with some evidence of jaundice already? What's the difference? What's going on? Why would a baby have jaundice early on after delivery? Anybody know? This might be something that would be good for you to look up a video on, maybe on Khan Academy or Osmosis or something about bilirubin, what it is. Okay, you have a red blood cell, right? Our red blood cells in our body carry oxygen, right? So they have molecules on them, a hemoglobin molecule on that red blood cells, in that red blood cell. If something causes that red blood cell to break down, that's called hemolysis. When that red blood cell breaks down and that hemoglobin is disassociated from that red blood cell and then broken down farther into heme and globin, then you have bilirubin produced. Okay, bilirubin is produced. So whenever red blood cells, whenever a baby is bleeding, something's causing bleeding, the bilirubin levels go up. Okay, if some bleeding is occurring. Okay, and this is pathologic. Okay, so pathologic jaundice usually is associated with some kind of blood incompatibility. So if you transfuse, if you have a client that needs red blood cells, they were an MVA and the provider has ordered packed red blood cells, and you do the double check when you go pick the blood up in the blood bank in the hospital. It's cross-checked. You and the lab person check the name and all the numbers. When you go back to the room to give that to your client, it's checked again with another registered nurse before you hang it, because of the possibility of an interaction between the blood types. Okay, so if you give the wrong blood to someone, they definitely have reactions. Okay, fever usually is a first sign, or your client might actually say, as you start the transfusion, and I just don't think this is going to be good. I just don't feel good. And that's not a good sign. There is something about when a client says that makes you really wonder. Okay. So in utero, if mother has some antibodies that have been developed, if she's Rh negative and she's carrying a baby with D antigen, her body recognizes that as an enemy. So they will actually attack fetal red blood cells. So that baby is born with some anemia, probably because of the hemolysis, and they become jaundiced right away after delivery, if not at delivery. So that's a pathological jaundice. And it turns into hyperbilirubinemia, the number 8 and above. So let's start with birth injuries. So you've got a big baby, you've got a diabetic client, macrosomic baby above the 90th percentile or 4,500 grams, big baby, vaginal delivery. So you think about injury to the baby as well as the mother. Okay, it's not always about the baby. Okay, shoulder dystocia might cause a brachial plexus injury right here. So I'm going to move this over here. Brachial plexus injury and a fractured clavicle. Here's brachial plexus down here. This baby. Okay. Also, clavicle fracture. Okay. Erb's palsy is a brachial plexus injury. The nerves in the neck are damaged from shoulder dystocia, okay? Because the head was hyperextended on one side. And then that side of the neck, those nerves in that neck that innervate the arm and the hands and the fingers is damaged. And it's called Erb's palsy, shoulder dystocia, okay? Shoulder dystocia broken clavicle, skull fracture from traumatic labor, humeral fractures, facial nerve injury, this one here, right here, forceps delivery. Sometimes we'll call facial nerve, it damages the facial nerve. These are temporary injuries. They do resolve. It sometimes takes a little while, but they do resolve, like facial nerve injury, it will resolve. And you can tell this baby is able to move the right side of the face, but not the left. Okay. Cephalohematoma is a hematoma that builds, that grows on the scalp. So it's in the soft tissue and it's localized in one area. So you just have a single swelling. This baby is susceptible to hyperbilirubinemia because of the bleeding, okay? The bleeding that's going along with the hematoma. And this is kaput. It's edema, and that's damage of the veins in the soft tissue. And this is a cross, so it's not localized. It crosses all those suture lines. And then the skull fracture down here, actually this compressed skull fracture is the worst that could happen. A linear fracture is sometimes not as serious as a depressed skull fracture. That could cause intracranial bleeding. Okay. So those are the birth injuries. So sometimes the actual neurological injuries, and now we're talking about the brain. Okay, neurological. What causes damage to the brain of a fetus? It could be labor and delivery. Now, a brachial plexus is a peripheral nerve. It's a peripheral nerve down the arms, right? A neurological intracranial, so in the tissue, brain tissue itself. Remember, babies have very fragile cerebral capillaries, blood vessels, very fragile, okay? And it's if there a lot of hypoxia occurs during labor, it's the same thing as a myocardial infarction. When there's inadequate amount of oxygen for the tissue, it causes ischemia, which damages the muscle, like a heart. Well, ischemia is going on in the brain, it's going to damage brain tissue, like a stroke, okay? There are babies who have intrauterine strokes. Sometimes it's not obvious until later in life, like at a year or so. Then we need to do some scans. So ischemic injuries. And we're thinking mainly of preterm babies here, okay? Preterm babies. So we protect our preterm babies, remember, by giving magnesium sulfate during labor if mother's preterm. Hyperglycemia can cause damage to the brain, cesarean surgery, precipitous labor. Infections, okay, during the intrapartum and the postpartum. Torch infections are infections that are passed from mother to baby during the pregnancy, okay? And it has to do with the primary infection. The first time mother is infected with toxoplasmosis, or the first time she's infected with cytomegalovirus or HSV, okay? That's the primary culprit for damaging a fetus, okay? Once we're exposed to toxoplasmosis as adults, we develop antibodies so that if we're ever exposed again, then we don't get an infection. So if the first time a mother gets infected with toxoplasmosis is when she's pregnant, that means the baby is not protected either. Okay. So you don't have to memorize all of these. Okay. They present very similarly. Rash, manifestation in the eyes, and irritability. Sometimes we don't know exactly what it is. Now, we do know syphilis is rash on the hands and feet if it's stage 3. Okay. Cytomegalovirus, Zika virus, microencephaly. What is that? What's microencephaly? Anybody know?
The baby is born without a brain or small brain.
Okay, small head. Yeah, small head. Yeah. Anencephaly is no brain or less. Some of the brain is missing. A starts with an A. Okay. So you don't need to memorize those. So when we think about exposure of a fetus to an infection during labor, we're talking about chorioamnionitis. Okay. And if we don't treat it, it can develop into pneumonia or meningitis. Usually group beta strep develops into meningitis. So if we don't become very aggressive with neonatal infection, then it can easily cause the death. So any client with a risk to develop an infection, a very long labor, a difficult labor, these babies are at risk to develop an infection. Okay, prolonged rupture of membranes. Okay, so what things would you see in a newborn if you suspected an evolving infection? What kinds of things, what do you think you would see in a newborn if they have an infection developing?
High fever.
Okay, a fever. Okay, a fever. What comes with a fever?
Increased heart rate, increased
Okay.
respiratory rate.
Okay, yeah. All right, good. So signs of an evolving sepsis or severe bacteria in the bloodstream. Sometimes we get it mixed up. Differential diagnosis with poor feeding and lethargy could also be hypoglycemia and respiratory distress, hypocalcemia. Okay, but usually evolving infection, poor feeding and lethargy, respiratory distress, tachypnea, hypothermia or temperature instability, especially in the preterm. Hypotonia. Hypotonia means the muscles are just very relaxed. There's not much, they're very soft. It's hard to describe. Hypotonia also occurs in respiratory distress. Okay, so hypotonia, abdominal distension, vomiting. And if you notice that the white blood cells are going down, they're dropping, that's an ominous sign of sepsis. Okay, so poor feeding and lethargy are some of the early signs. So if you have a newborn that is not interested in breastfeeding, kind of lethargic, get their temperature, okay? So other than supporting their respirations, their hydration, we're going to get some more information. We want to see what their CBC is. We're going to do some cultures. We're going to do cerebral spinal fluid, maybe blood cultures, at least urine and stool cultures. We need to continue for these babies to receive breast milk for the antibodies. That will help. So we also have talked about substance use in pregnancy before. Now let's think about what it does to these babies. It depends on what drug we're talking about, right? When the last time mother used it, how dependent she is on it, what kind of drug it is. So it's not just the illicit drugs that we're concerned about. The prescribed drugs, if you have a client that is taking medications for ADHD, these tend to be stimulants. And so she's dependent on that drug. And we might see effects in the newborn. Antidepressants, they might be prescribed and it might be good for our client to be taking them, but she is dependent on those drugs because if she stops taking them, she'll have a withdrawal symptom. And so we're thinking about that as far as the baby. Anti-anxiety drugs, the benzodiazepines, Xanax, lorazepam, all those drugs. It's going to slow mom down. It's going to slow baby down. Baby's going to be sleepy, as well as with the opioids. Okay, so if mother is in a pain management program from some kind of trauma history, and she's on medication, opioids for pain management. If we can't reduce it during the pregnancy, then baby needs some kind of help postpartum. If you have I had a client who was taking an unbelievable amount of opioids because she was having continuous pain from a motor vehicle accident she was in, and she was in pain management. She was taking oxycodone, 10 milligrams. It wasn't OxyContin, but it was oxycodone, 10 milligrams 4 times a day. Okay, she was super dependent. And to get her to cut back a little bit during pregnancy, that was a real challenge. But we knew what to expect with the newborn. So usually a child like that, if mother's not willing to try something different and to cut back a little bit, we do have to treat pharmacologically that newborn with some morphine. You can't put someone like that on Subutex. It's not going to work. Polydrug use. Polydrug use. What does it mean? Mother using more than one. So what are you going to see in a newborn if a mother's taking more than one kind of medications? You can read the pathophys here, but we're going to talk about it a little bit more straightforward. So withdrawal, neonatal abstinence syndrome. You notice this baby? Baby is not flexed except for the arms. You notice how straight those legs are? They're not flexed. Okay, she looks a little stiff. This is common for neonatal, and this baby is crying. Going through withdrawal as a newborn, what you would see, the autonomic nervous system is overacting, you might say. So yawning and sneezing, mottled skin, temperature instability, fragmented sleep. In other words, they have trouble going to sleep. They have trouble staying asleep. Nothing is regulated. They're dysregulated, okay? They're uncoordinated in their sucking and their swallowing. So they get restless when they try, and they'll swallow a lot of air. Then they'll have colic, and then they'll have vomiting and diarrhea. It's myotonic jerks. You know, sometimes when you fall asleep and you're just getting ready to go into deep sleep and your body jerks, those are called myotonic jerks. Myotonic jerks. And we see those in NAS babies. Hypertonic muscles, stiff, rigid muscle tone. and a failure to thrive. Okay, these babies consume a lot of oxygen, a lot of energy. So what do we do for them? We use the Finnegan scale. The Finnegan instrument is a way of assessing a newborn to determine if they need pharmacological intervention. Pharmacological. So we might have to, like I said, it depends on what mother was using. We might have to give some morphine and then reassess and try to wean that baby down. These babies need to stay in NICU for at least 5 days after delivery. Okay. What can we do non-pharmacologically? What are we teaching our mothers? We want mothers to be really participative in the care of their new baby. Okay. What can we do to facilitate that bonding with that new baby? Dark room, quiet. We're going to limit stimulation because that tends to get them more upset. Okay, limit both visual and auditory stimulation. Gently swaddle them, wrap them tightly in a blanket, hold on to them, and vertically rock them. Okay. Side lying position. When you put them in the bed, put them on their side in a C position, like they were in utero. Clustering care means you're gonna assess and bathe and everything in a certain amount of time, and then you're gonna leave the baby alone for a longer period of time. So cluster. Don't go do one thing, come back, go do something else. Cluster, do everything in a specified time to get it done, and then leave the baby alone. Okay, we don't want to overstimulate. Skin to skin is very important for these babies as well. Anybody have any questions about this? Fetal alcohol syndrome. We don't know how much alcohol it takes to damage a fetus. So we just basically instruct our clients not to drink any alcohol, to completely abstain. Okay. So what we'll see in a newborn that's been exposed to alcohol is a low birth weight, emotionally labile, and cognitive impairment. And then abnormal, we call them facies. Okay. Abnormal facies. I actually had a client that had fetal alcohol syndrome and she got pregnant. She was an adult. And indeed, she was cognitively impaired, but not so bad that she couldn't take care of her own baby. But she was very emotional, extremely emotional, extremely. She was like a 6-year-old, basically. But she stepped up to the plate and she ended up doing well during labor and postpartum. Everything went well. She needed a lot of support. Postpartum, her boyfriend left her shortly after the baby was born. So that made it even worse. So that's fetal alcohol syndrome. It tends to be a spectrum because, you could have it really bad or not as bad, that sort of thing. Tobacco use during pregnancy, the intake of nicotine in any form reduces the size of the baby. Okay, it reduces the nutrition to the baby. Okay, it constricts the arteries. So these babies are going to be small. There's an increased risk of miscarriage during that first trimester. The placenta is not healthy. Increased risk of abruption, and of course previa and preterm birth. Also, breastfeeding. If a client breastfeeds and she smokes, she's going to have difficulty producing milk because of the effects of nicotine. Okay, and not only that, but the baby is exposed to secondhand smoke. Okay, so we see asthma develop at an early age in these babies. This is pictures that you can study in your own time. This is about ABO-RH incompatibility. I thought it was a great way to describe it. So just take some time to look at that. Remember, if there is any incompatibility, that means mother's antibodies are going to attack the fetal red blood cells. Maybe not in the current pregnancy, the first pregnancy, but the next one. Okay, and that explains it in that picture. Once again, it causes fetal anemia. Okay, fetal anemia. The breakdown of the red blood cells causes anemia in our newborns. Anemia means they can't carry as much oxygen when they're born. Okay, so they're going to be jaundiced, like this little guy is here, little girl right here. Jaundice because they have all that broken down red blood cells and all that bilirubin in the tissue. So we need to feed these babies. Breastfeed preferably, so they have the addition of the laxative to get rid of the bilirubin through the stool. So feed, and sunshine. Or a bilirubin blanket, a bilirubin light. So this is the most severe form of hyperbilirubinemia with a blood incompatibility, okay? You'll see the petechiae, okay, from liver damage. The purpura, which is just the extension of petechiae, the bluish color discolorations. If a baby, just like any person, has anybody ever experienced anemia? I mean, pretty severe anemia. If you don't have enough red blood cells, you don't have the oxygen carrying capacity. So chest pain, muscle fatigue, fatigue all over, okay, weakness with severe anemia. So a newborn is going to experience the same thing. Severe fatigue, severe anemia, heart failure, okay, can cause stillborn if it's so severe that it occurs during fetal life. The baby will actually have an enlarged liver and spleen because of the breakdown of the red blood cells. And they could develop what's called fetalis hydropsis, which is fatal. So that's your hyperbilirubinemia, and it's usually caused by blood incompatibility. Hemolytic disease. We've talked about, I feel like we've talked about diabetes ever since day one of this course. Okay, look at this fat baby. This is definitely a macrosomic baby, right? So what are your priorities assessment with this baby?
Blood sugars.
Okay, blood sugars definitely, because they're going to be hypoglycemic early. Blood sugars, breastfeeding, what else? In your assessment, what do you really need to pay attention to?
Respiratory status and vitals.
Respiratory status, because respiratory means that they might have some distress because they don't have enough surfactant. Remember, with our diabetic babies. Okay, so we need to quickly hypothermia, hypoglycemia, and respiratory status. Just because they're big and fat doesn't mean that they're doing well. Okay, don't let that fool you. So why is the preterm newborn more susceptible to hyperbilirubinemia? The preterm. Anybody know?
Does it have to do with their lungs not maturing?
Hyperbilirubinemia.
Oh, I don't know then.
Well, their liver is very immature. Okay, that's part of it. And they're more susceptible to hemolysis.
Is it because the red blood cells
Mm-hmm.
in the short life?
Mm-hmm.
Okay.
So what are some typical characteristics of a newborn? What would you see, in other words? What do they look like? Just use your own words. What is, if you look at a newborn, what do they look like? Okay.
I don't know what to say. I feel like that's really broad, so I don't want to say the wrong thing. Oh, small.
Okay. Small, scrawny. Head is a little bit larger. I mean, it's physically obvious. Okay. The head is normally a little bit larger than the chest, but for a preterm, it's obvious. Lanugo, fuzzy skin, very thin skin because there's not much subcutaneous fat there. But that's your newborn. And let's do this case study. Soon after birth, Anthony is the baby, 33 weeks old, with a weight of 25.75, so kind of a low birth weight. He's exhibiting signs of respiratory distress. So they move him to NICU, 50 miles from where the baby was born, because it was a rural hospital where he was born, and they need to get him to a tertiary care center that's better equipped with trained providers. Okay, so he's going to the NICU. The mother, whose name is Leslie, was discharged from the hospital 24 hours. Okay, so a mother was still at the old hospital, and she's very upset, as you can imagine, and anxious. She asked the nurse why Anthony is having such difficulty breathing and what can happen. So at 33 weeks, usually newborn lungs are not mature. It's not usually until 35 weeks. So she's worried. Why is she so worried? Well, she's wondering, why is he having trouble breathing? He's 33 weeks. So the nurse discusses preterm infant physiology and complications with Leslie. Okay, choose the most likely option for the information missing from the statements below. Okay, so number 1, number 2, number 3, number 4. These are options in the chart. This is another next gen style question that you might come up with. So they're going to ask you to fill in the blank, basically. So for number 1, choose 40, 34, 38, or 36. Okay. Infants born before blank number of weeks gestation have an increased risk of respiratory distress. What's the right answer? Pardon?
36.
Okay, we'll say 36. All right, before 36. That's true. Number 2, so immaturity of what organ system places the preterm infant at risk for complications? So think about the organs that are immature, and the more premature that baby is, the more complications there will be. So is it just one system that we're concerned about, or is it 2 systems, or is it 3 or 4? This one I had trouble answering. Now, what are they asking? Most? My guess would be most. Most organs are immature. Okay. Including what? So option 3, then they want you to identify the complication because of the prematurity. What is one complication of prematurity? Options for 3. Tachycardia, acrocyanosis, respiratory distress syndrome, hypertonicity. Which one is a complication of preterm baby?
Respiratory distress syndrome.
Yeah, so this is number 3. Okay, and then lastly, what's the other one? What other complications are there for a preterm baby? Hyperglycemia, hyperbilirubinemia, hypocalcemia, or polycythemia?
Hyperbilirubemia.
Yeah, hyperbilirubinemia. Yes. Okay. So the NICU, so let's say you're the NICU nurse. You're performing a physical assessment on this baby, on Anthony. Anthony's vital signs are axillary temperature of 35.8, respiratory rate 70 breaths per minute, heart rate 150. He has some intercostal retraction, nasal flaring, and audible grunting during expiration. So you're going to place a cardiorespiratory monitor on the baby and a blood pressure cuff and a pulse oximeter. Okay. What else? What additional nursing assessments and interventions in the immediate care of Anthony are warranted? Select all that apply. What else would you do? So you have to look at your data again. Okay, so vital signs, temperature 35.8, is that normal? Breath at 70%. No, that baby's cold. So we definitely need to choose a radiant warmer, right? Okay. Respiratory rate is 70 breaths per minute. Flaring. Do we want to put the baby in the prone position? No, Kelly says. Maybe a side lying position? Yes. Do you want to wrap the baby with 2 blankets and a hat? If you put a baby in a radiant warmer, you don't need to wrap them in a blanket, but you could put a hat on them. So no. Vigorously suction the airway? Never. Okay. Record pulse oximetry reading every hour? Yes. So usually in that situation, we get an x-ray and determine, do we need to give surfactant? Okay. Okay, so the nurse recognizes that the birth of a preterm newborn is very stressful for parents, and they may experience a variety of feelings such as guilt, anxiety, helplessness, and ambivalence. The nurse formulates a plan to help facilitate the parent-newborn relationship with mom. So the paragraph down below there, if you're reading it, says, are you reading the paragraph below? Is everybody ignoring me? Everybody seems disconnected with me. Y'all are distracted by something else. Okay. So there's some stress going on in the relationship here because of what they've experienced. So what are some ways that we can facilitate the baby and the parent relationships? Facilitate means to help it move along, okay? Leslie feels discouraged, but do we want her to bottle feed? No, that's not a good way to build bonding. Maybe refer Leslie to a social worker for assistance in finding transportation to see her baby. Definitely. Keep Anthony wrapped in 2 blankets when Leslie holds him so he doesn't get too cold. I don't know why 2 blankets. I would say that's not a good answer because it could be 3 or, that's just when it's that specific. Explain the treatment plan in correct technical terms. Kaylee says no. So you need to put it in layman terms, right? So she understands it. How about discourage parental involvement so that the baby doesn't tire out from too much handling? No, we don't want that. Remove some items related to therapy. If he's under a bilirubin light, we've got his eyes covered. But if they're going to hold him, we need to remove those iPads. So that's true, if possible. So learning how to take these kinds of questions is going to be important. So remember what the signs of respiratory distress are. Tachypnea, respiration rate above 60, dyspnea, difficulty, and then no breathing, apnea. So how many seconds of apnea are acceptable? Or is there any amount of apnea acceptable? Emma, are you there? I don't see your head. Emma? Emma? I think Emma might have fallen asleep. Emma, I'm going to have to remove you from class. Okay. Corey, tell me, how much apnea is acceptable in a newborn?
Probably none.
Okay, well, we do allow up to 20 seconds. Nothing beyond 20 seconds. Okay.
That seems like a long time.
It does. It does. It does. So if you see 15 seconds, 18 seconds, you need to just document it and monitor. Okay.
Yeah,
Keep your eye on that baby.
That seems excessive given their respiratory rate to begin with. I don't see how they could have that.
Yeah.
20 seconds of apnea.
Well, we don't want them to have 20. Okay, so pronounce intercostal, the retractions. When you auscultate the lungs, they're wet, grunting, flaring, signs of cyanosis, central cyanosis. What about acrocyanosis? You remember what that is?
Cyanosis of the extremities.
Yes, yeah. So if you have a newborn that seems to be going downhill, okay, the vital signs are dropping. Blood pressure is dropping. We usually don't take a blood pressure, but if we have a baby that seems to be struggling, we will get a blood pressure, apnea, and then temperature instability. The temperature fluctuates. So we have a nurse or a client, Allison. She was 30 weeks gestation when she delivered her baby, Tommy. And you're the nurse, you're getting ready to do a detailed head to toe assessment because baby has bonded with mom for 2 hours. Baby's been over there being nursed, being fed, and now it's time to do a head to toe. What would you be concerned about when you looked at your newborn and the abdomen was distended? And what would be your next assessment technique?
I would think a possible bowel obstruction. So you would want to listen to the bowel sounds.
Okay, excellent. Yeah. So we need to auscultate the tummy, distend. Once we auscultate, then, this would be a good time to percuss. Is it fluid? Is it air? Or is it nothing going on? Okay. And then palpate. What could be going on? Bowel obstruction, Kelly says. Good answer. So we're going to talk about that in a minute. Retinopathy of prematurity. This is simply remembering that tiny blood vessels that supply the eyes and the brain are very fragile of newborns. So premature ones especially. So if those blood vessels are damaged by a lot of oxygen pressure, in other words, if you are giving your baby oxygen and it's at 40%, which is way too high, you can damage those blood vessels, okay? So we're gonna cover the eyes if they're in an oxygen tent, okay? And we're gonna keep the pressure of the oxygen at a low flow meter, okay? So retinal vessel immaturity. So low birth weight babies, so we need to reduce hyperoxia. So that's what retinopathy of prematurity means, damage to the retinal blood vessels. So necrotizing enterocolitis, don't let this scare you. Remember we were talking about the baby with the distended abdomen? Should have this one down here. Okay, so Kelly has a baby with a distended abdomen and she suspects that there's some kind of bowel obstruction going on because she sees that the abdomen is distended and she decides she needed to auscultate. So what did you hear when you auscultated, Kelly?
If there was a perforated bowel or a bowel obstruction, you would have absent bowel sounds.
Okay. So you would have trouble hearing any bowel sounds, yeah. So what other things that you might see is lethargy in this newborn and not interested in feeding. Hypotension, vomiting, apnea, and the list goes on. So specifically with necrotizing enterocolitis, you're going to see a distended abdomen. It might not be apparent. It's not something we see at birth. It's something that evolves. It's an infection, okay? So distended abdomen and often shiny in appearance. The stools are bloody if they're passing stools, okay? Gastric retention. So that's what the vomiting is, okay? An area of the abdomen that's erythemic. Remember, their skin is very thin. Induration means it's like this. Vomiting bile. So what's going on with necrotizing enterocolitis? Anybody have any idea? What is necrosis? What do we mean by necrosis?
Dead tissue.
Dead tissue or dying tissue, okay? So when we think about a preterm baby and all of those fragile blood vessels and immature circulation, the thought is that necrotizing enterocolitis is the intestines are not getting adequate perfusion of blood and they're beginning to die. Okay, they're necrotizing and they're beginning to die, so stool can't pass through them. Their abdomen becomes distended. And this is, it could be really, really bad and baby doesn't survive, or we can intervene, do surgery, and remove the dead bowel. Okay. Treat with antibiotics. Sometimes if we overuse antibiotics, it could lead to necrotizing enterocolitis because we're destroying all the normal bacteria. Okay. So it's dying bowel. Okay. So you're going to see the distended abdomen. So if you have something like this on an exam, they're going to want to know what you would see in a baby with NEC. So you want that distended bowel, shiny, absent bowel sounds, or hypoactive anyway. So those are the two. There's other, your book mentions bronchial dysplasia and other lung issues that can occur with long-term ventilation where the lungs are damaged by pressure. So we've got an extremely premature baby that we've been ventilating. Sometimes those lungs are damaged from ventilation. And then we have our post-term baby. Okay. So post-term, bigger babies. Okay. They're susceptible to birth injuries too. And so what you're going to see, they're not going to have any lanugo. Vernix might be completely gone. Okay. A lot of hair, as if because they continue to grow in utero. Longer fingernails. Their skin is often cracked, almost like peeling off, like paper, peeling paper off. So, kind of wrapping it up here, when we care for high risk, we're always focused, categorized, respiratory thermoregulation. So we have to support their respirations, keep them warm, hydration, and skin integrity. If you think about a baby that is going through neonatal absence withdrawal syndromes, they're very hyperactive. They're restless, they're moving around a lot. We're worried about skin integrity because that skin is rubbing against the linen, okay? Protecting babies from infection, okay? Hand hygiene, okay? Hydration, nutrition, baby's nutrition, certainly breastfeeding promotion, and then bolus, gavage feeding tubes. This is a picture of this baby. It's got a CPAP on, but there's a tube in the stomach right now. And usually feeding tubes go through the nose. But this baby has to have CPAP. And this is a picture then. You can see the feeding tube in the nose. And this was what you would call a bolus gavage feeding. With breast milk, that gives that baby everything it needs. There is in your text on page 615 some guidelines for skincare and newborns. We do have assessment tools that we can use to document skin assessments and interventions. So I just pulled out some of them, using a pH solution, neutral pH cleansing solution. Make sure no fragrances or any additives in it or dyes. Don't aggressively remove the vernix. It has its purpose. Allow it to just wear off. Okay. use semi-permeable bandages or paper tape. Silicone, you know, the Coban that you can, the kind that you can wrap around and sticks to itself is a good thing to use too. Gel mattress for sure. Keep the skin clean. Avoid antibiotic ointments and powders. Okay. This is a lot of this antibiotic ointments is also something you want to inform your mother and father not to use excessive ointments or powders on the newborn. Okay. All right. Any questions about that? Well, probably not. I know you probably haven't really looked at anything. The PowerPoints and stuff I shared with you, the ones from today, and there's another one I posted for you. Make sure you look at those, and as you're going through your text, use it as a guide to look at your text to fill in what I don't have there for you. Okay. I think I gave you a Word document also with notes from what I took from the text so that you can read that as well. All righty. So your case study, your discussion question this week, and your NCLEX question. So your NCLEX questions should be from, once again, the category of health problem, and just choose maternity. Or you can just choose newborn. Either one is fine. Okay. If you just choose maternity, it'll pull everything up. But if you choose newborn as well, then you'll get all that newborn stuff that'll help you with your exam. Your study sessions this week in your announcements. So make sure you go to the live session if you didn't go before for the other exam. And Emily. Okay. If during Zoom class, if you're knocked off because your computer died, that's really not an excuse, because you know that we're here for 2.5 hours. So you should have your computer plugged in, or at least have availability of a power cord in reach. Okay. If you get knocked off because you're in a storm, that's a different story. But if you're knocked off of Zoom and yet you're able to finish your quiz, then you weren't really knocked off your internet. Okay, so I understand that things can occur during Zoom, but not being here, not being on camera, like Azzy right now is not on camera, is not an excuse. You know how to adjust your phone or your computer to show your face. Okay. And you know, that's just being responsible. You're going to be a registered nurse someday. You have to be responsible. And learning it now is important. If you're not paying attention during class, if you're not prepared, I'm wasting my time, you know, talking to you, because you're not going to remember a lot of what I said today. Because if you didn't write notes, you're not going to remember. And most people don't. If you're not an auditory learner, you don't remember what I said today. Okay. I do share the recordings with you, and I'll post this one in week 8 announcement. So if you were distracted during this time by something else, or you're tired or whatever, you need to watch the recording again. Okay. Azzy, are you there? Okay. All right. So it's really, you know, because sometimes students do fall asleep during class. And if you're not sitting up in a chair, if you're laying in your bed, you know, you're going to fall asleep. Okay. So don't lay in a bed when you're in class. You need to sit up. in a chair. Okay. So we do have just a few more minutes. I'm going to open up quiz 4 here, and I'm going to talk about it. And so that you know the commonly missed questions of quiz 4 or concepts. So the difference between a previa and an abruption. What's one significant difference between the two? What would you say?
Previa is when the placenta is covering the cervix, and abruption is when it came through.
Okay, so when the placenta pulls away, the difference between the two is abruption is going to be a lot of pain. Okay, a lot of bleeding, a lot of pain, rigid uterus. Okay. Labor dystocia. What you had to remember about labor dystocia is all the P's, the 5 P's. Once again, labor dystocia. Is it because the baby's too big? Is it the passageway? Is it because she can't push, or are her contractions irregular? Things like that. Is she obese? So if she's obese, yeah. If her BMI is above what? What's obese? What's a BMI of an obese person? Above what number?
30.
30. And then umbilical cord prolapse. You're not going to push the cord. I told you that in class. You're not going to be pushing on the cord. You need to reposition your client first on knees and arms.
The knee to chest.
Knee to chest. Yeah. Knee to chest. Okay. Let's see what else here. Let me look at somebody else's. What's pica? Do you remember what pica is?
Wanting to eat ice chips and it's commonly linked with iron deficiency.
Okay, good. Hyperemesis gravidarum.
Excessive vomiting.
And they usually their potassium drops. They have an electrolyte imbalance. And that's how we diagnose it. A normal fetal heart rate pattern. Above 110, below 160. Early decelerations are fine. Variable decelerations are not good. Moderate variability is good. So you need to know reassuring heart patterns. A lot of you wanted to choose pushing the cord back into the vagina and missed the placenta previa and the fetal heart rate, a normal fetal heart rate pattern. Diabetics. We want them to have strict blood glucose control. Okay, exercise. Okay, so those are the biggies. If you want to go over your quiz specifically, I'll be glad to go over it with you, but you have to let me know. Okay. So this week, if you want to go over what you missed on the exam, if you didn't do as well, or if you did super and you just want to still see which concept you didn't get or what you missed, let me know. Okay. All right, everybody go take a nap. I'll see everybody next time, okay? You can sign off. Bye-bye.
I had a question for you.
Yes, Kaylee.
When are you available to go over my exam?
Let me see.
Let me get a
here.
note. Let me get a note card out so I can write it down so I don't forget.
So tomorrow, what's your schedule like tomorrow?
I don't have anything tomorrow. I have an exam review with my other teacher at 11:30, I believe.
Okay.
Let me make sure.
Okay.
But that would work. It would help me get all of it done in one day, actually.
Yeah, that's true. So you want at 11:30, do you want it, is 11 o'clock? We would get everything done before 11:30. Is that good for you? Or that pushing it? You want 10 o'clock? Let's see, where are you? Are you in
I'm in Eastern time zone, so I'm in Centerville, Ohio.
okay, oh, Centerville, that's right. Okay, so 10 o'clock in the morning, 10:30, you know, whenever you want. Or I also could meet you at 1 o'clock or
Okay.
at 2:30.
So I didn't miss a whole bunch, so I think 11 will be all right.
Okay, yeah, it doesn't take that long.
Yeah.
Okay.
So I think 11 would be good, and then I can just
Okay.
hop on the Zoom with her right after.
All right, all right. All right. I'll see you tomorrow then at 11.
All right. Thank you.
You're very welcome. Bye-bye.
Bye.